All right. Good
So
morning,
you should be
everybody.
good. Thanks for joining us, Rob.
No problem. I changed this up. If you've seen this talk a little bit over the last couple of years, I took my boards last year, so I tried to highlight some of the things that were questions. Am I allowed to say that? Should we be recording this? I tried to highlight some of the things that may stand out on your exam moving forward.
Promise not to share it with anybody except
Right.
our fellows.
Not exact questions. So I don't know what the exact questions are, but I do remember seeing these. I do remember seeing some of these on the exam. So we're going to talk about peripheral nerve entrapments. Cartoon here. Hopefully by the end of this talk, you'll know which nerve was entrapped in this cartoon. Let's see if it's going to move forward. There we go. All right. So objectives, we're going to discuss locations and treatments of peripheral nerve entrapments, wrist, elbow, shoulder, hip, knee, ankle, and foot. We're going to start with the wrist and work our way proximal. So starting with the wrist, the main one is going to be carpal tunnel. Everybody should know it's the median nerve. It's the most commonly entrapped neuropathy. It's going to be compressed by the transverse carpal ligament versus a ganglion cyst. More common in women, more prominent in the dominant hand. And then you have that median nerve distribution. Thenar eminence can be spared if the palmar cutaneous branches, if the palmar cutaneous nerve branches proximal to the carpal tunnel. This is where you can get into trouble a little bit with some of the percutaneous releases, carpal tunnel releases. There are a couple of products out there that some of the primary care sports medicine physicians will use to release the carpal tunnel or that transverse carpal ligament. And so you have to know your ultrasound pretty well and be able to see those nerves well so that you don't cut it when releasing the carpal tunnel. Phelan's and Tinel's tests are the most specific. I kind of feel like there's not a lot. The carpal tunnel is being the most common nerve entrapment. I feel like the testers don't love the most common thing. It's always the second most or the third most common thing that they like to test on. And as you'll see as we go through this tends to be a lot of rote memorization and anatomy more than anything else. So again, in the wrist, we've got the ulnar nerve on the medial side of the wrist, weakness of the hand, again, that compression at Guillen's canal or that palmar carpal ligament. Worse with riding a bike or manual labor. A lot of times this is trauma. So you'll get this, that hook of the hamate fracture. So baseball players swinging a bat, golfers, those sorts of things. Ganglion cysts or ulnar artery thrombosis. And that's pretty much it. Feel free to stop me as we go through if you have questions about a particular joint, but that's pretty much it for the wrist. Moving on to the elbow, there's a lot more at the elbow. We've got three major nerves in the elbow, the median, ulnar, and radial nerve that can all be entrapped. And I think when you're going through this, the important thing is to remember the anatomy and kind of where these nerves can be entrapped. So anterior, the median nerve is going to be anterior, covered by that bicipital aponeurosis. It's going to travel between the two heads of the pronator teres. The anterior interosseous nerve supplies the deep muscles of the forearm. And we're going to go into these kind of in more detail. This is just a broad overview comparing the three nerves in the elbow or at the elbow. Ulnar nerve is going to be posterior medial in the cubital tunnel under the FCU. That's going to be your second most common entrapment of the elbow, or of the upper extremity. The radial nerve, anterior lateral, travels between the brachialis and brachioradialis. The PIN is the big one that seems to get trapped that we see a fair amount. It's motor only, supplies the distal radial extensors. And then you also have the superficial radial nerve coming off of there that's more sensory. So ulnar nerve entrapment, again, compression at that cubital tunnel. underneath the arcuate ligament. Again, underlining that one. Progressive loss of grip strength and pinch strength. You get wasting of the thenar and hypothenar eminence. So you're going to get wasting of both, as opposed to the carpal tunnel where you're only going to get one. Elbow pain spreading down to the wrist. The ulnar nerve may be tender. Tennell's test, pain with elbow flexion. So you can see that, and you really should do dynamic tests here just to see if you have any subluxing of the nerve that can cause, even though that's not compression, it can mimic it. So you want to make sure you check for that. Benedictine posture, and then Frohman's sign. Frohman's sign you can see down here, gripping the paper, where you can't keep that thumb flat against the paper. That IP joint tends to be flexed or is flexed. Radial nerve palsy. This is Saturday night palsy. It's in the spiral groove. It's not really compressed by anything anatomic. It is compressed usually by a bar stool. I've seen this once, and he showed up about 2 weeks later, and at that point it was done. He never got it back, and that was back in residency. Concern with humeral head concern with humeral shaft fractures as well, so it can be damaged during that. Numbness in the lateral dorsum of the hand, and then they get very weak with forearm supination, elbow flexion, but have normal extension. All right, radial versus median compression. And these are the two that I think are the easiest to get confused. They like testing these. So that posterior interosseous nerve, it's a deep branch of the radial nerve. Good to know what it comes off of. Compressed at the arcade of Frosch, origin of the supinator muscles. They've gotten away a little bit from using named anatomic structures, so I think it's more important to remember that supinator muscle supplies most of the extensors of the hand and wrist. There's no sensation loss with this, so that's a big one. So that posterior interosseous nerve, supinator muscle origin, and no sensation loss. The median nerve supplies the anterior interosseous nerve. Branches of the medial nerve at the elbow arises between the two heads of the protonator teres. Again, important to remember that. Motor deficit without sensory loss, and they can't do the OK sign. We got a chat here. Yep, often on the CAQ.
Sorry, I was trying to be non-obtrusive by doing it as a chat instead of a comment, and that
No
didn't work.
problem.
Keep going, Rob.
Thanks. So I think this is an important slide here. There's a lot of information on this slide, and they can really test just about anything on this slide. One of the ways I remember the difference as far as where they come off is main. So median anterior interosseous nerve. If you can remember main, then you'll have a pretty good idea of which one it's coming off of for that. Oh, lost. Yep, there you go. So again, just remember where they get compressed. That's it for the elbow. So we're going to go pretty quickly through here. We'll get you some time back today. But shoulder suprascapular nerve is the big one. And this one can actually be pretty impressive. I remember seeing one of these in my fellowship. We had a wide receiver, had maybe about 3-4% body fat. Came in, he had a ganglion cyst in that sphenoglenoid notch, and so his supra spinatus was spared, but his infraspinatus was almost completely atrophied. It was very, very obvious. So it was one of the things that I always remember about fellowship. But you get from the suprascapular nerve, if it's in the notch, you're going to get wasting of both the supra and infraspinatus. You'll have that inability to laterally rotate or abduct the arm. You will get some posterior pain. If you get that compression, you're going to get both If it's at the suprascapular notch, if it's in the sphenoglenoid, you're only going to get the infraspinatus. A lot of times it's caused by repetitive activities, ganglions, tumors, or direct trauma. His was a ganglion. We drained it under ultrasound, and his infraspinatus came back pretty quickly. So again, just remember where they're compressed. And that's pretty much it for the shoulder. So we kind of got, anybody have any questions about anything in the upper extremity? All right,
No,
moving
but
on.
I'll, Rob,
Go ahead.
I'll add that last thing you just discussed about the suprascapular notch. That was on my CAQ when I last took it. Differentiating
Yep,
between the notch and sphenoglenoid notch.
yep. All right, so we're gonna move on to the hip. So getting into the lower. So this is the answer to the question at the beginning of the talk, right? The lateral femoral cutaneous nerve, that neuralgia paresthetica. You get burning and numbness of the lateral thigh. There's no reflex or motor deficit. So this is all sensory. You can do Tinel's at the inguinal ligament. It's going to be worse with walking, wearing a heavy belt or tight underwear. So you can see this also with a large pannus. I've seen that once, where they got rid of everything and nothing. There was no tight belts. They weren't a police officer or a handyman or a construction worker that was wearing some sort of tool belt. It was just the obesity that was causing that, and it was just on one side. So doesn't have to be bilateral. But this is something that can be hydrodissected. You can try it and see. You're not going to damage any motor skills, and they do appreciate getting rid of that discomfort because it can be disturbing. They state that it feels like there's always something in their pants pocket, or at least that's what people have described it to me as. Sciatic nerve. Sciatic nerve compressed at the piriformis or deep to the piriformis, and about 15% of people, the sciatic nerve pierces the muscle. So that's one thing you got to kind of keep an eye out for. Is this caused by spasm? This is a little bit of a black box. If again, with all of these, and I think if you've worked with me, we start conservative and go aggressive. And so you start with physical therapy and work your way all the way up to injections and then further if they don't get any relief. But a lot of the times it can be something as simple as moving their wallet from the right pocket to the left pocket, or stop using wallet in the back pocket at all. So not much on sciatica. Again, kind of a black box. A little bit more understandable is going to be that common peroneal nerve at the fibular head. Usually involves the deep and superficial, but the lateral cutaneous nerve is spared as it comes off proximal to that area of compression. You get weakness with the ankle and dorsiflexion and eversion. Sorry, the lights go out here if you don't move for like 3 minutes. Sensory loss over the dorsum of the foot and lateral calf. Tinel's test over the fibular head and neck. Again, you can cause this by crossing legs, squatting, ganglion cysts. Good to evaluate this with an ultrasound and see if there's anything there that can be aspirated, maybe taking some of the pressure off. So we'll move from there into the foot. Tibial nerve compressed at the tarsal tunnel under the flexor retinaculum. So again, flexor retinaculum is a good thing to remember. Worse with weight bearing, Tinel's over the tarsal tunnel, possible wasting of the intrinsic muscles of the foot. Can be misdiagnosed as plantar fascia. I think there's another one that mimics plantar fascia a little bit, plantar fasciitis a little bit more. But this is one that we do see. I get asked to inject a lot of these, especially in people that have had traumatic fractures, either of the calcaneus or foot. A lot of the people that have any kind of hardware through the calcaneus or the talus will get some discomfort, and they ask us to see if it's coming from the retinaculum, whether there's some sort of tarsal tunnel here. And most of the time it doesn't help. It's from the arthritis and the trauma that they've already endured. but it's worth trying because if they do get some relief, at least they have something to go after then. So again, remember that flexor retinaculum. Baxter's nerve, this is one that does get named, if at least whenever I've seen this on tests, it's one that they will use the name, but just remember it's the first branch of the lateral plantar nerve. It can mimic plantar fasciitis as it comes down. It's easily found, and easily is depends on the quality of your ultrasound, but you should be able to find it pretty easily. And then if you have any questions about whether or not that's causing your plantar fasciitis, you can certainly do a diagnostic nerve block and see how much relief they get. Usually they get pretty good relief if it's not. And that's pretty much my talk. There's a lot. This is a good one to go back over. I did before I took my CAQ last year. It certainly helped. There's not a whole lot of nuance to it. It is really just kind of memorizing these things. Happy to take any questions. All right. So that's it. I appreciate everybody getting on early. I've got patients starting at 8:30, so I figured a half hour was enough, but apparently I can get through this in about 15 minutes. So I appreciate everybody's attention. Have a good weekend and enjoy St. Patrick's Day.
Thanks.
It's Rob.
No problem.